welcome every participant who's here, who's come in to learn a lot. I personally feel there is so much that an optometrist can do, but there is so little that is been done. We are restricting ourselves into the refraction cabins and a very little bit here and there, or maybe more into investigative ophthalmology. But personally, I believe 30% of the patients who walk into the clinics actually need a good optometry care. The diagnosis also has to be at the end of the optometrist while he is doing the refraction. Many of you may be doing it, but we still feel there are some who are not doing it. Another thing is, whatever we learned at the universities or at the school level, time is evolving. It has changed so much that every day new science comes in. Frankly, whatever I studied at my university level is totally obsolete. And very recently, the topic that we chose is amblyopia management. Not only amblyopia, I would say binocular vision anomalies. It's a big percentage which comes to you. And even if we talk about especially the digital eye strain and not the accommodation and convergence problems. But today's topic we are specifically focusing to amblyopia because we have really studied that we manage the patients with occlusions. We've also studied that 7 years is the critical age for managing any amblyopia. Some of you may not know that yes, there are patients who are adults can also be revived back with their vision. And the whole philosophy of treating a patient from monocular to binocular has moved on. The techniques have changed. It's no longer those synaptophores or prism bars or other kind of arrangements that you should be requiring in your clinics. Everything is evolving. And unless you update yourself and understand, I think you'll not do justice to your patient care. This topic that is covered is co-management. The ophthalmologist and the optometrist really need to work very hard to bring in the best in the patient care. Inviting our guest, Oliullah Abdal, Oli in short for all of us. He's an optometrist and he's the co-founder and director of Bynocs, of which we're going to be taking this session through. Oli has been not only now specializing in binocular vision but has turned into research and innovation. And one such innovation comes from him. He has been such a big researcher to develop this first, as a pioneer dichoptic vision therapy for amblyopia and anti-suppression. He's won many awards for it. 2019, the AIOS Top Innovation Award in Ophthalmology. He also won the Pitch Challenge American Society for Cataract and Refractive Surgeon Award in 2020, and in 2021, it was an achievement to win the Top Innovation in Health Technology NASCOM Award. And I think personally these awards are not from these industries but from every patient, and my personal experience, it's an award or a reward which your patient will also give you if you do the right management. Oli has been an excellent, I think we are proud to have him as an optometrist colleague with us, who has achieved these kind of technologies and research to bring it to us, and one of the unique latest therapies for it. You can continue to post your questions in the chat box while the session is going on, and we certainly would have a long discussion hour. Over to you, Oli.
Thank you. Those are very encouraging words and a lot of appreciation. Though still I'm an optometrist and very hardcore clinical optometrist rather, I would say. And it's absolute pleasure to be part of this workshop or the lecture series from Learn Beyond Vision, and definitely Center for Sight giving me this opportunity to discuss with the team of optometrists or maybe ophthalmologists who are present today for this topic today. We know this amblyopia management is one of the most traditional concept of managing patient with amblyopic visual disorders, and it is an old aged treatment method that we have. However, over a recent time, we are seeing a lot of perspectives are changing. Rather, you could say that paradigm of amblyopia management is changing, as Monica mentioned, that it is moving from a monocular approach to binocular approach. Now, why do we think that this paradigm shift is happening? To understand that, we have this today's session. So we will try to understand first what actually happens in this visual pathway, or what are the amblyogenic factors that are affecting the visual pathway in amblyopic patient, and what are the expected outcome with the newer technologies like binocular vision approach. So if you quickly look at this visual pathway, we all know that the visual pathway, especially in amblyopia, we consider that the first level of neurons, which are the photoreceptors, the bipolar cells, and ganglion cells. These are absolutely normal. So when I need to term something as amblyopic, I need to make sure that these are absolutely fine first and foremost. So if there are any pathologies here, we should not term them as amblyopic. There could be amyloidogenic factors associated, but they are not a pure amblyopic patient. Now, what actually happens in amblyopia starts at the lateral geniculate body and into the visual cortex, Brodmann area 70, and extra striate cortex. So we'll go deep into it a little bit more. And this was one of the Nobel winning concept of explaining this mechanism of amyloidogenic factors. So if you look at lateral geniculate body, if there are early deprivation in the visual stimulus, then the cells of the lateral geniculate body become pale and shrunken. So when something is pale in visual system or in the optic nerve head, we say that the functionality of that particular neurons are suboptimal. It is affected. And that constitutes your inefficacy in giving a better resolution acuity. Now, when something is shrunken, that means it is more prone to give you crowding effect, because in the small space, you have a lot of information gathering, and that leads to crowding effect. So this is very well established, and we know that this happens if there are early deprivation into the visual information processing. That could be uncorrected refractive error, or maybe obstruction to the pathway, like there are ptosis or cataract during early childhood, or there could be a strabismic in nature where patient is not paying attention or visual attention. Now, what is most important here, that if you do not cover the eye, which is dominant in nature, better in nature, there would be no recovery. And that's why the patching concept or the traditional treatment works when you cover the good eye and then it recovers from the other eye. So vision starts recovering. Now, this is very important to know that we do have plasticity period for this particular pathway, when it is said to be that around 7 years or 8 years or maximum 10 years of age, where the plasticity is still there. And up to this stage or this age, if you still do the patching of the good eye, you get the visual improvement. And we all know about this treatment protocol. Now, this do not talk about diffuse atrophy. So there was no atrophy, that's why visual could recover. And we see almost all these patients who improve with patching falls into this category, right? Now, interestingly, what happens in the binocular pathway, that if you have this kind of visual information which are affected, then in the Brodmann area 17, more precisely 4C, the inputs which it gets into the visual system or the visual cortex are markedly shrinked. So as in, what is happening if the amblyopic eye sending the inputs from the eye to the brain, the stripes which are there, which is actually mapped into functional MRI, so those becomes markedly shrink. And as you know, whenever there is a shrinkage of one area into the visual system, what would happen, the other eye, which is getting a better inputs, will try to expand it, and slowly it will start to dominate over the amblyopic eye. And this is exactly what happens in the amblyopic patient. So the eye which gets a better stimulus starts getting better and better inputs into the visual cortex, and the expansion of that visual area or the visual cortical area happens, and that leads to suppression of the amblyopic eye. And this is very critical information. Then when we say that the suppression is happening, we need to understand that the mechanism are binocular in nature, because one eye was dominating over the other eye, and that led to a newer development of therapies. So we'll come back to this aspect. Now, why we are looking for this new approach? So as we know the pathophysiology now, or rather neurophysiology, how the amblyopia happens in different conditions, as in different aspect, when it's a monocular pathway and when it's a binocular pathway, there are two different mechanisms, and predominantly is the suppression. Whenever there is a strong suppression, then the mechanism is more of binocular in nature. So let's see what we are doing by default. Like every cause of amblyopia, we know that we treat them first. If it is refractive error, we give them full refractive correction. If there is a strabismus, we try to correct them. Or if there is a deprivational amblyopia, we take care of those. Now, to gain the vision, what we do is traditionally patch the good eye by default. And that is not the solution for all cases. So this is one single image can explain you what all the issues that one can have with the traditional treatment approach. We would see a lot of patients coming with this kind of dull faces, and we know the actual cause of it. Let's dig into one by one. So first and foremost is the residual amblyopia. So in this treatment protocol, when we teach the patient to use the amblyopic eye, now on its own, it tries to develop the visual acuity. However, as there is no competition or there is no one to compete along with the amblyopic eye, it learns to see whatever the best possible, and thus resulting in suboptimal visual acuity gain. So it's like when you are not competing with somebody who is a real competitor, you never grow at that level. So for the amblyopic eye, it is happening that it is learning to see on its own, and it is improving maybe 612, 69. And if you see the meta-analysis which was reported in ophthalmology journal, that's most of the patient, you will have residual amblyopia. So more than 85% would have at least 2 lines of amblyopia still left if you treat at least like 6 hours, and that is in the age group which is younger is in nature. So you do everything, but still the residual component is very, very high. Apart from this, we have issues with compliance. So as we know, as some child is growing, the resistance to patching becomes more and more. If it is a younger kid, you can force them, you can do whatever task you used to do and then force them to patch the good eye. However, it becomes really challenging when the child becomes 5 and above. Now, for them, we have seen that the compliance rate goes down significantly. It is reported to have only 50% compliance to the standard treatment protocol when child is more than 5 years old. Right? So that leads to when there are no compliance and you know the success rate for any treatment is affected because of poor compliance. So this, additional to this, we have the time takes to improve the vision. So if you look at any patient that you treat with amyloia and with a penalization like patching or atropine, you know it takes a long time. So some patient you are patching for 1 year, some patient 2 years, some patient patching for 4 years. So for them, you are actually patching them years after years and trying to get the best visual acuity, visual outcome. And that becomes a very difficult for parents or the patient to comply with. So the improvement is really long. It takes to get recovered from amblyopia. Moreover, if you look at a patient who are older age group or adolescents or adult, for those patients, it really becomes an unsuccessful attempt with penalization. So if you do patching or any treatment for them, which is related to penalization, they are of almost no use. Even though there are improvement of a line, 2 lines with patching, the moment you stop patching, then you will have the reversal of amblyopia or recurrence of amblyopia. So we'll come to the next slide. So where it is termed as recurrence. So you have all the hurdle. You did 6 hours patching, you put full threshold to make it best possible outcome. But the moment you stop patching, you have the recurrence. So with all these demerits, as in we try a lot with the patching treatment or penalization treatment, we do get success, but there are major issues in terms of all these factors leads to thinking of a newer approach, newer treatment, which could be most effective, the quick results and sustainable results. Now, apart from this, we never thought of what happens to the patient binocular vision. God gifted us both the eyes, and both eyes has some definite functions like coordinated movements or a visual perception, depth perception. So everything is very important when God gifted us 2 eyes. And when we're training with any monocular approach, we know that it is forced to be use 1 eye, and we're missing out a lot of information, a lot of visual information for overall development of the visual system, child growth, or activities related to depth perception. So everything is affected. So we never looked at with the traditional treatment. We are always like how much patient can see on the Snellen's chart. And that was like a traditional thought process of just gaining the visual acuity, which is called resolution acuity. Now everything is changing, as I mentioned, that from a concept of this monocular approach, it is considered, though this was known to have a binocular impact, but it was not given a priority. Now every newer literature is suggesting or talking about treating amblyopia as a binocular problem. So whenever you think binocular problem, then the treatment needs to be binocular in nature. So you should target to use both eyes together, and the involvement of the visual information which is coming from both eyes, if you can sum it up, or the summation can lead to better and better visual outcome. As in this case, what is happening then, that you are giving guidance for the amblyopic eye from a dominant eye, that once upon a time I suppressed you to dominate over you, but now I am actually helping you or holding your hands to gain your visual acuity or other binocular vision functions. So this is how the binocular concept are growing. Let's see how we can achieve that. So there are very simple clinical environment you can create on your own to experiment. So this is one of the best technique I would rather always talk and then describe. So this is one of the concept. You have red green filters in your trial set, all of you have, and then you take any kind of content which is as you see that it is red and the green component when you have, and you put a plain filter, a filter which will have a similar color, either the red or a green filter. You get it from stationery shop or you get a gelatin kind of paper and put on top of it, then it gives that saturation of that particular task or the underlying task. And then you see through a red-green glasses and you see the change it cause or the perception into the visual system it gives. So when you cover the eye, which has a red filter, you will see that it is striking off anything which is red in color. Okay. And in the green filter will strike off all the green targets. So that means in a target which is there as a white background, it cancels the same color target. So if my right eye is dominant and my left eye is amblyopic in nature, what I will do is I'll put the filter such a way, and then I'll give a task for the left eye to bring my right eye, left eye vision better and better. So if my left eye has a green filter, I would rather give some target which is actually seeing from that particular eye. However, it is very important that the right eye should also see the field, the visual field or the area of interest. So very specific task to the amblyopic eye. However, the area of vision is binocular in nature. You can see it from both eyes. And this concept is termed as MFVF, whereas it's called as monocular fixation in a binocular field. Now you can create or simulate this condition at any given environment, whether it is in clinic or at home. So how do we create at home? So this is again giving tasks to the patient, drawing child's love to draw. If not love to draw, then what you can do is, okay, you put content like videos or watching any kind of content, putting this kind of red green filters, or you can ask them to do the home task with the similar color concept. Now this is the moment you start putting that red green filter in front of your eye and try to experience it, it will be more and more clearer. And then similar concept you can create with drawing, writing, or reading text. It's just example of a heart chart, but you can create with any reading material, or even a content on television or a screen, like mobile, tablet. You can you can put the gelatin paper or a filter and then convert into a particular aim or like area of color or the interest, color for your interest, and then give that particular task for the eye, which is amblyopic in nature. However, patient should be able to see the environment under binocular state. So we are actually not occluding the dominant eye. You are just guiding both the eyes together so that the amblyopic eye know what is my competition or at what level I should reach to match the dominant eye, and the visual acuity along with binocular vision functions start improving, right? So it is like holding your hand to start walking or driving a bicycle, or riding a bicycle, driving a car, or swimming. So all these things, when you have a coach or when you have somebody to train, you learn faster and better way. Similar way for a visual system, when there is a guidance, how to develop, what to develop, how much to develop is always a better approach to gain visual acuity and other binocular vision parameters. Now, if you note in this concept, as you are taking the binocular vision from the day one of your treatment, any patient, in spite of having anisometropia, high anisometropia, or maybe any other condition, are less likely to develop any kind of double vision if you bring them out of separation. So usually for us, the scare is that, okay, what happens if I break the separation? Patient might be diplopic, and the diplopia is worse condition than having a monocular acuity. I agree with that. But as this program is taking care of your visual system maturation under binocular environment since day one, you will not get the diplopia, which is intractable in nature with any binocular approach. So let's see, there are different games that were developed in the Android and placed like iStore. So few of them. So this is very familiar game, which was like prescribed 3 to 4 years back, every doctor used to suggest to their patient where like they ask the patient, okay, play this game, stereo blocks, lazy eye blocks from Duovision. So these are freely available games, but there are also paid version of it. Now it was effective if the patient could do in a proper way. However, the issues were there, the control over the size of the target and the other parameters like crowding effect and then the speed component, those things were not able to control with this environment. With this Tetris game, however, the effectiveness was reported as like in 2009 or 10, a good amount of improvement was noted, but this is very effective when it is done under supervision of anybody. So similarly, you have this game Lazy Eye Snake, and then in the Apple like iPad and iPhones, you get Lazy Eye Bubble Shooter. You also get Lazy Eye Breaker. So and Jump and Fly. So these are all games which are based on the concept of monocular fixation into a binocular field. Okay, so you could create in clinic. You could have a luxury of having this kind of games. Could be a free version or paid version. It is effective to give you a patient anti-suppression activity, right? So if somebody is suppressing from amylopic eye, they will come out of suppression very nice way. Now what happens next when you are breaking the suppression? Now it is task for the visual system to improve the resolution acuity. Patient starts seeing smaller and smaller targets. Patient should able to appreciate better contrast, better binocular vision functions, and that's why these games were ineffective to yield a very good level of visual acuity and binocular vision functions, right? So with this based on this concept, things were getting developed, and this is happening past 1 decade. And then recently we saw, okay, from a Japanese company, they developed something called Occlutab. So they tried to make it binocular in nature, but very similar to patching, but not as a complete monocular, because in this case, what they are doing is they're creating an environment from the dominant eye completely white background, whereas the amylopic eye gets specific task. I'll show you the next screen. So it actually bleach the dominant eye. So in this case, if you see that the left eye is bleached and the patient would able to see targets only from the right eye. So one of the eye with a polarized filter, the screen is polarized in nature. So as you see, a naked eye would see a white screen. However, through the polarized filter, one eye would see that some targets are there. So it is a good concept of giving some binocular activities where the dominant eye still can see the environment or the background. However, the tasks are being performed from the amylopic eye. So very similar concept what I have explained in red-green filter with red-green filter. Now this is again good as patching treatment, but at the same time as bad as or as limited as your any penalization treatment, because you still have issues with the efficacy, the recurrence, and all those problem issues in the binocularity. Now this was one of the article published recently in Indian Journal of Ophthalmology, where they reported by 8th week, patient could improve around 3 lines of visual acuity improvement. However, over a period of time, the moment they stop the treatment, patients start regressing visual acuity. So there are almost all patients started deteriorating their improved visual acuity and then become amblyopic again or suppressed at one point of time, as very similar of patching modalities here. So moving forward, there are a different approach as well. So there is another one from Israel. So first one was from Japan. I showed this is from Israel called Cureside. And in this technology, it is again a digital partial patching approach. You might have heard of something called Bangater filters. So very similar technology or concept they're used. And what they do over here, I'll show a video, a small video maybe. Let me see if I have the video. Right. So they are using this red and blue anaglyphic dissociative tools. And additionally, what they did is they have put an eye tracker at the bottom of the device. So what it does, it notes the movement of the amblyopic eye. So wherever the target of interest for the amblyopic eye is going, it blurs that target, only that particular target. So child can watch a YouTube video or can go to any kind of content which are embedded into the system, Cartoon Network or anything. But as you see, it is blurring the specific target from one of the eye. So the eye, the dominant eye, gets a blurred image. So overall resolution acuity of that eye becomes blurred. So it's like a digital partial patching of that eye. However, the environment is again binocular. So as you see the evolvement or it's the treatment evolving to more and more of binocular in nature. So from a complete white screen for the dominant eye to a partially blurred screen for the dominant eye. So the interaction between both the eyes happens faster and you could get a better results. Now in this treatment, you get good amount of improvement in mild to moderate amylopic cases. However, it is still not sure what happens to the suppressed condition, because earlier treatment, what you saw, even in suppressed condition, it can help. However, recurrence was major issue. In this case, it can work in mild to moderate and give you better results, as these games can improve the stereopsis. So in this case, as you see, over a period of time, patient's stereopsis improve. Now there are technologies, so we got this different concept evolved, and we observed what could be improvised and looked at different aspect. So we got this dichoptic based binocular activities, which are completely binocular in nature. Here we're not reducing the dominant eye resolution acuity. So we are always working with a similar kind of resolution acuity in the dominant eye and non-dominant eye, and introducing the visual concept by adjusting the contrast. So let's see what actually happens in the contrast adjustment. So just to brief you, when you have a patient with amblyopia and suppression, so the dominant eye would boss over the non-dominant eye, and as you see, the brain perceive only one image. But the moment you reduce the contrast, brain starts seeing both the images together. And that explains that by changing the contrast, the ocular dominance column can actually start perceiving both the images together. So that is one of the unique feature of adjusting contrast and seeing it. So in this case, as you see, that we have not looked at the decreasing the resolution acuity. Only by adjusting the contrast, you are gaining the binocular activities. And based on that, there are multiple games which can take care of the resolution acuity, patient's frequency to the target, crowding effect, binocular vision, like developing the fusion and stereopsis. So all those components are taken care of. So in an activity where you are trying to take care of patient's resolution acuity, or like anti-suppression activity, or developing the binocular vision like fusion and stereopsis, all are embedded into one system. And it is programmatic in such a way that based on patient visual improvement or improvement in the different visual function, the treatment would, or the activity will change its parameter on its own. So we have recent publication out of 161 patients. This was just a couple of weeks back. And again, we saw around 4 logMAR lines improvement happening over just 6 weeks time. So 6 weeks, as in like in a patient whom we are treating for years and years, if you enroll for binocular treatment, actually you can get improvement much superior than any kind of penalization only in 6 weeks time. And not only the visual acuity, the amount of binocular vision they improve. So if you look at the left side bar, it started a patient who are like overall 65% patient or 66% patient do not have like stereopsis to start with. It was absent, but at the end of the program, 90% actually developed it. So only 10% still left by end of 6 weeks. However, all these patients were extended session. So we extend the session for another 4 to 6 weeks for the completion. And we do see that more than 95% of the patient do develop the stereopsis. So that is the biggest advantage of going for any kind of a binocular approach, not a partial one, a complete binocular approach. So there are classical cases to discuss today. So this is again, last time also I discussed at Gurgaon branch, but this is very classical. Routine OPD, we see a lot of patients coming with this kind of scenario. So they must have got for a job or something, they went and they realized that, okay, one of the eyes is severely amblyopic and suppressed, and they are expecting by doing any kind of refractive surgery will take care of their vision. It is a very common question. If I do my LASIK or if I implant a lens inside my eye, my visual acuity is going to improve, right, doctor? Or right, optometrist? Or right, am I right? But the answer we give in a different way, that whatever you do, your visual acuity going to remain same. Now, as a patient, I would rather not go for any treatment because I want my visual acuity back, because I am looking for some kind of job, or I am not getting my driving license, especially in Western countries or Middle East, where the visual acuity parameters are mandatory, even in some Asian countries, or even in Australia, Singapore, there the visual criteria is very important. So with this kind of visual acuity, I'm not going to get my driving license, and I need a solution. So as of now, if you look for only a monocular approach, there is no solution for them. However, if you look at a binocular angle and enroll for a program like Bynocs or similar to that, you can get very good improvement. So now this patient agrees for any kind of refractive surgery you suggest. They can go for a specialist contact lens, or they can go for implantable Coleman lens, or even they can opt for other phakic implants, or some doctors may look for LASIK procedure if the corneal thickness are optimal in nature, even in this high refractive error. So a classical case like this can be handled and managed in the best way with a binocular approach like Bynocs treatment. Next case could be another classical example. So patient underwent multifocal IOL implant at, as we know that at 65, most of the patient now, and there is a demand for multifocal IOLs, but after IOL implant, we realize that patient visual acuity is suboptimal in one eye and very unhappy. And what the patient would blame at the first point of time, that something is wrong with my surgical or IOL calculation. So the blame goes to either on the biometry or in the doctor's surgical skills. However, as a clinical perspective, with a plano diffraction, we know that this is the best possible biometry can be done and the surgical intervention can be done. Then if you dig into more and you realize, okay, patient was hyperopic in nature in that eye, and there was anisometropic amblyopia since childhood, and patient never disclosed prior cataract surgery, because over a period of time, patient visual acuity decreased in both eyes and never realized, okay, I should have mentioned before opting for a premium IOL like multifocal IOL. Now, what is the solution? Now, if you look at any Western countries, they would rather go for IOL explantation. We have classically, this case was posted for IOL explantation in that eye because patient was not getting used to. So this patient was enrolled for Bynocs, and we could improve the visual acuity to 6/7.5 only in 6 weeks, and the amount of binocular vision they gained was enormous. So patient become good, and visual comfort was very good, started reading from both the eyes together. The multifocality effect were best because patient could see from both the eyes together. So this was another classical example where a quick screening for amblyogenic factors can guide you a better treatment approach even at the age of 65 post IOL implant. Now, as we saw over a dichoptic training, what all things can be achieved. So whatever approach you go beyond the traditional monocular approach, in a binocular way, if you look at, in a dichoptic, the compliance become good because somehow it is gamified in nature. So whether you look at the Tetris game, so something is to play with, or a similar game, jump and fly in the store, so it becomes more engaging, and with other gaming activities or watching content on Cartoon Network, or maybe with a Cureside, or even a program like Bynocs, where there are different activities are there. So wherever there is a component of gamification, so the adherence, the compliance level becomes better, and patients start enjoying it, playing it, and that results in a better outcome of the program. The improvement of the visual acuity is quite fast. You can achieve 3 to 6 log multiply visual acuity improvement only in 6 weeks time. If there are more amyloidogenic factors or a denser amblyopia, you can extend it at any point of time. And most of the dichoptic training can restore patients' binocular visual functions like fusion and stereopsis, and it is effective in older age group. And the last but not the least, it do not give you recurrence. What is very important, that once you achieve the treatment, it should stay there, it should be sustainable, and it should maintain the visual acuity and binocular vision that it gains, and which is very evident with the dichoptic approach. Now, whenever you look for this dichoptic approach, there are certain inclusion or the criteria, what would say you need to look at, that there are certain patients may not suit for this program. And for those are, first and foremost, do not enroll a patient who has manifest deviation. So if somebody has manifest deviation, that needs to be corrected prior Bynocs or any kind of binocular enrollment. The reason being, when you have a deviated eye and you are like giving a binocular approach, so you are going to stimulate a non-foveal point into the deviated eye. So better not to give binocular approach before correcting the strabismus. Very, very crucial point. Now, if somebody having microstrabismus, still it is very difficult to manage. The prognosis is guarded. And if somebody already developed eccentric fixation, then the prognosis is very poor. As we know, as we go away from the foveal centralis, the density of the cone and the size of the cones become lesser and lesser. And as we have lesser density, we'll have more crowding effect. As we have lesser size of cones, we'll have more issues with the resolution acuity. So the differentiation ability between 2 points will be more difficult, and that leads to a resolution acuity deficit. So with this context, we know that what are the boon for dichoptic approach and what we need to really keep in mind before enrolling into any binocular or a dichoptic approach treatment. And if you are rightly into the assessment and managing the patient, you could get very good results with these newer modalities of amblyopia treatment. And we look, this is, or we see the future in management of amblyopia lies in binocular approach. And there is a huge paradigm shift that is happening in recent years. Thank you for your attention, and I would love to interact and answer queries that you have now.
Thank you so much, Ollie. You have taken up the session so well, and I love to listen to it again and again. Simply summarizing for those who are here again. So we do understand compliance with occlusion, which seems to be a very common thing, that patch and then everything is okay. But patching, I know, or when we come across the parents' ordeal to let that child be patching, it's not easy. Compliance is not poor, and we've seen recurrences. In fact, for years together, we see these parents and children coming back to occlusion again and again. Another thing we learned today is we're not occluding the good eye and going by our old philosophy. There is something else which is done. You're rather stimulating both of the eyes to work together. So it's a binocular phenomena now that we are treating with. Age is no bar. Vision could be improved at any age, provided we undergo the criteria. Most important, we do consider that there is no squint or an strabismus before starting these therapies. Stereopsis, we are always talking about binocular vision, but the major improvement that has to happen is just not 6/6 or 6/9 vision in the amblyopic eye. What should be thought of is restoring the binocularities of both these eyes. And most important, the highest grade of binocular vision is stereopsis. So if we can achieve all this, we sure would have the successful patients. Ollie, there is one question which I think before anybody else opens up and, the ice breaking happening, the question which keeps coming back again is it occlusion added along with this therapy, or is it still occlusion, without occlusion, these therapies are given? I mean, it's a common concept saying occlusion and this therapy. What do you have to say on to that?
Right. So definitely this is the most commonly encountered dilemma. Rather than question, we say that it is always for a clinical perspective is a dilemma that what should we do? As we know, the occlusion is standard treatment of care at this point of time. However, the mechanism of action, as I mentioned, that it works with the monocular pathway. So we're actually trying to work with the pathway or the neurons which are more up to like a monocular neurons, and trying to work within that plasticity period of monocular neurons. Now, when you combine with any binocular approach, in the binocular approach, you are not supposed to stop the stimulus from the dominant eye. In this case, rather you have to ask the dominant eye to bend to a level where it can go along with the amblyopic eye. So if you stop completely, the stimulus from the both the like dominant eye, then it would not give you a result which is expected in a binocular approach. So still it will act as a monocular approach treatment. So even if you combine both the treatment together, the results are going to be very similar to what you get in monocular approach. So binocular approach effectivity is not going to get if you combine with patching. So in a simpler summary, that do not mix and match together.
I think this is one of the biggest paradigm shifts, which even I didn't realize when I started with these vision therapies, software based. Our mind was still stuck on to occlusion therapies, and then we moved on to giving these vision therapies together. So I think it's a great message here to say when you are doing the vision therapy software based, we do not combine it with occlusion therapy. And that's a great compliance achievement in the end, I would say.
So the rule of thumb for amblyopia management is that first and foremost, you have to take care the motor alignment, especially in binocular approach, so that the patient can get bifoveal stimulation. Okay. So if you have a strabismic amblyopia along with an isometropia or maybe refractive error, it could be meridional or anything. So try to align the eyes with the best possible diffraction or additive prisms you can give, or if needed, a surgical intervention. So that is the first criterion is to be met, followed by definitely the best possible refractive correction. Do not undercorrect. So that is another, because until this you give a proper refraction to the retina, you are going to get inferior quality image. So it is very important that you give a complete diffraction or a full refractive correction for this patient and enroll for a binocular approach. So step one, taking care of the motor misalignment, that means taking care of the strabismus first, and that can be taken care with Usually two ways. One is prism adaptation and second is a surgical intervention. So you need to choose what is the best approach for that particular patient, whether it's a prism or a surgical intervention that you would like to go ahead. And second step is again looking at a complete refractive correction, and third would be binocular approach. Is going to give you the best result.
Ollie, what would be the role
Okay,
of
thank you.
contact lenses in this? We are talking of full correction, like the case, 24-year-old male case also that you
Right.
presented. It's a -9 and we're going to go for therapy.
Right.
How about prescribing contact lenses?
The best approach. So as we know that whenever the anisometropia, the difference is usually more than 4 diopter, then you tend to get patient non-adaptability with the refractive correction that leads primarily because of the anisoconic effect that they have. And that can be avoided based on prescribing a right pair of contact lenses. And with contact lenses, it's not only the anisoconia is being taken care of, but it's the binocularity. The development of binocular vision is much faster, and we have seen great results with those.
In fact, one of the concepts which we have been usually coming across, people thinking that let's improve the vision first and then to maintain we'll have the contact lens. So friends, very important, the moment you have these kind of anisometropic amblyopia cases, the first step, full correction and a good contact lens, and then start with the therapy.
Sure.
So what is the best minimum age to start this Bynocs therapy? Like at what age one child or one patient can understand the mode of this therapy, mode of this software?
Great. I think very interesting.
Anything is there?
Yep. So as long as the child knows how to operate the keyboard, and today's time, you can't predict that who is going to use the keyboard better than me. So we have seen usually 4 and above, but there are some smart kids, as you see, that they can operate the keyboard. Arrow keys, they need to play with the arrow key onto the keyboard, so they knows actually at 3.5. But usually 4+ age group is ideal candidate. But there could be some child at 5 also, they do not know how to operate the keyboard. So based on the child intelligence and the experience with the computer keyboard is important for Bynocs program.
Okay, so there is a question which comes in to say, is it the same as revital vision therapy? Because this therapy, I think, is available already in the hospital. If you could compare the difference between these.
Sure. So it's entirely different concept, though it is aimed to treat the same condition, which is amblyopia or suppression. So if you look at the technology perspective, we are into a contrast adjusted dichoptic therapies. Revital vision focus on Gabor patches. So if you had a chance to look at the activities, there are black and white stripes with very similar to FACT chart, contrast chart, where just to identify the stripes, orientation, very similar for revital vision to identify those orientation of the target at different contrast, so that the patches, the Gabor patches, stimulate the visual pathway in the brain, and then it gives you results. Now, as a principle, it is very good in nature as long as it is stimulating the visual cortical cells. It is very good, definitely. However, we have seen as a experience, practical experience, what happens that after a couple of minutes time, because of the monotonous in nature with the similar kind of stripes, so we find out in a dark room procedure, patient try to lose the the attention goes off. And then, as you know, if the compliance to any treatment is not there, the success rate is not going to be there. So if the compliance lost, you lost the entire treatment protocol. So that was the major deficiency we saw with the program like Revital. However, as a technology perspective, it is a very good concept to treat amblyopia.
Yeah, and I think compliance is one of the keys.
Right.
Making the patient sit there and keep talking about directions, right, left, up, down, it's certainly the interest is not going to be there.
Right.
Okay, last question which comes in is, how long will it take to do this test? I think one of the questions was in the feedback form. It's talking about sessions. So usually the patient does come to ask if I'm going to go for this therapy, how long and what is the session. I know it will be individual, but if you could just general tell us about these sessions.
Sure. So standard treatment protocol for a Bynocs program, I'll give a very precise one, is 30 minutes active session. So when I say 30-minute active session means patient needs to do active gameplay for 30 minutes, 5 sessions a week for 6 weeks. So total a 30 days program, half an hour a day, that means 15 hours of active vision therapy, right? Now, if the patient were taking break in between or between 2 games, taking rest, those are not considered. Active gameplay of 30 minutes a day, 5 sessions a week for 6 weeks.
I think that's a very useful thing to be told to the patient so that he is mentally prepared of what it is talking. Remember again, it is operating from home and you will be monitoring these patients through your own system. You don't have to sit in for the 30 minutes the patient is doing those therapies. It's the initial visit where you will be training and then the patient continues to do at their own leisure time and pace, and hence later you keep monitoring and your monitoring will tell, yes, this is the time now the therapy is done. Is that so, Oli?
Absolutely correct.
I would like to also say, you don't have to have your patient for the therapies coming to the centers. It is all online, and I would like Oli to describe the process, how it is, because most of the time, what is going across in the market, the patient is asked to come back to the clinics and there are sessions given there. Even the assessments are done in clinic, but we would be doing this through Bynocs online and can be even work from home kind of modality. Can you please elaborate on this, Oli?
Sure. So yes, I think COVID do have some positive effects on us. Definitely it taught us that how we can take this binocular or vision therapy to the doorstep of the patient at their convenience. So what with Bynocs you can actually do is do the assessment, their sessions and the progress monitoring, everything virtually. So you would like you need to just connect over the Zoom call with the patient, share the screen, and then start doing the assessment, therapeutic program, as well as looking at how the patient is doing the progress. So it's that during the diagnosis, when the patient is already coming to you, so you know that this is already diagnosed patient of Amylopia, counsel the patient, they can go home, enroll for the program. Obviously, they subscribe to the program from hospital, and once they go back, they start the process. And once they are completing the entire session, so the module of treatment, so usually 6 weeks is the first benchmark of checking what is the progress, and that can be definitely can be assessed through the Bynocs program remotely. And once you feel that patient attained the best possible visual outcome, call the patient back into the clinic. So it's the first session and the last session you call the patient into the clinic, and rest everything can be managed at home. So is the travel time, is the appointment schedule, everything can be decongested and you can manage the patient virtually from like home.
I think that's the beauty of it. Because, right. And the only thing you would like to add, what are the tools that would be required for assessment of online steps?
Correct. So the first is one need to have LED screen. It can be a laptop or a desktop. We need a video calling platform like Zoom, and today's time almost everybody has because of the online schooling and everything. And then for dissociation, we also provide this kind of dissociative goggles. So these are called Bynocs 3D glasses, and patient needs to just put this on top of glasses. So usually almost all CFS would have their these glasses in their inventory. If not, you can definitely ask from the central branch. It is already there into the system. So you can ask them or indent them so that it reaches to you.
So for the therapy, the patient needs these glasses, and If not, they can be loaned to the patient at a security. The test can be done, and then for the therapy, it can be extended.
It's very minimal amount. These glasses are very expensive in nature, so it can be couriered to the patient wherever they are. And it usually done by like either from the clinic or from the Bynocs team can courier that. And once they reach, we can start the process completely.
Yes. So another way we said that optometrist, everybody may not be interested to take it forward. The regional heads can perhaps nominate some of your institute or region optometrists who are good in binocular vision, can take it forward and can be specifically given a series of sessions of training with this software where they can then be the link with any patient who's been asked to do these kind of therapies. Is that the best way, I think, Oli, that can be done at this institution?
Yes.
Yes. We would end up and sum up the session today. Thank you, Oli. It's been one of the excellent sessions. And I think it's a beginning now. It's not only understanding amblyopia, there is a lot more of science in accommodation and convergence anomalies, and the whole orthoptics and the binocular vision science has evolved into a software system. There is so much to teach and learn from each other. And as optometrists, it's our domain to make sure that we get the best, whether it is a multifocal fit patient who has problems with vision or a patient who's coming over for LASIK and he needs 6x6 vision post LASIK. Thank you so much. If you still have questions, you can send us and we will forward, and we look forward to many more sessions from you, Oli.